All right, today we're tackling a big one, a high-yield classic for any medical exam you're ever going to take, Tetralogy of Fallot. If you want to really understand the most common cyanotic congenital heart disease, well, you are in the right place. Let's dive in.
So let's kick things off with a classic case. Picture this. A 6-month-old is brought in. The baby has a bluish tint to their skin, cyanosis, and it gets way worse when they cry or try to feed. This specific clinical picture should immediately make a big diagnosis flash in your mind. By the time we're done here, you'll know exactly why this screams Tetralogy of Fallot.
Here's our game plan for today. We're going to break down the 4 core defects, get into the pathophysiology, why it all happens, then we'll look at the clinical picture, how we diagnose it, how we manage it, and we'll wrap up with the absolute must-know takeaways.
Okay, first things first, the 4 defects. The tetra in tetralogy means 4. But here's the wild part. These 4 separate anatomical problems all stem from one single mistake way back in embryology. The infundibular septum gets displaced. It moves anteriorly and superiorly. Let's see how that one little shift creates this whole cascade of problems.
Defect number 1, a ventricular septal defect, or VSD. But listen, this isn't just any little hole. It's a huge malalignment type. Seriously, think of it as a wide open doorway between the right and left ventricles, letting blood just slash back and forth between them. Second, we have pulmonary stenosis. This is a narrowing, a bottleneck right at the exit of the right ventricle, leading to the pulmonary artery. And this is the most critical piece of the puzzle. Why? Because how narrow this path is, that alone decides how sick the patient will be. The tighter the stenosis, the more severe the disease. Period. Number 3 is the overriding aorta. So normally, the aorta should sit squarely over the left ventricle, right? Well, in TOF, it's shifted over. It's straddling that VSD we just talked about. And because of its position, it ends up getting blood from both ventricles, oxygenated blood from the left and deoxygenated blood from the right. And finally, our 4th feature, right ventricular hypertrophy. Now, this isn't really a primary defect. It's more of a consequence of the others. See, the right ventricle is a muscle. And it's working overtime, constantly pushing against that tight stenotic pulmonary valve. And what happens to a muscle that works against resistance all day? It gets bigger. It hypertrophies. So we've got our 4 defects laid out. Now let's connect the dots and talk pathophysiology. How do these 4 structural problems lead to that classic blue baby syndrome? It all boils down to a story of blood taking a wrong turn, a tale of shunting. In a normal heart, pressure on the left side, the systemic side, is much higher than on the right. But in Tetralogy of Fallot, that pulmonary stenosis changes the game completely. The right ventricle has to squeeze incredibly hard to push blood past that bottleneck, so hard that the pressure inside the RV actually becomes higher than the pressure in the left ventricle. And here's the direct result of that pressure flip. You've got higher pressure on the right, lower pressure on the left, and a giant VSD connecting them. What's going to happen? Physics takes over. Deoxygenated blue blood from the right ventricle gets forced across that VSD into the left ventricle. It mixes with the good, red, oxygenated blood, and this purple mixture gets pumped out to the body. That's the right-to-left shunt, and that's exactly why these babies turn blue. Now that we've got the plumbing and the pressure dynamics down, let's see how this all plays out in the real world. What does this right-to-left shunt actually look like in a patient sitting in front of you? Typically, symptoms start to appear around 3 to 6 months of age. You see that cyanosis we've been talking about, shortness of breath, and because it's just plain hard work for them to eat and breathe, these infants often don't feed well and have what we call failure to thrive. But the most famous, most dramatic feature is something called a TET spell. So what is a TET spell? It's a sudden, terrifying episode where the baby becomes profoundly cyanotic, like deeply blue. It's often triggered by something simple, like crying, feeding, or even having a bowel movement. These things cause a temporary drop in the body's overall blood pressure, the systemic vascular resistance. When that happens, it suddenly becomes even easier for that high-pressure right ventricle to shunt blue blood over to the left side, making the cyanosis way worse. Now, you've probably heard of this classic image, an older kid with untreated TOF who, after playing, instinctively squats down. This isn't just some random quirk. It's the child's body doing something absolutely brilliant to save itself. It's a powerful compensatory mechanism. Let's break down the physiology because it's so cool. When the child squats, they kink the big femoral arteries in their legs. This action jacks up the pressure in the entire arterial system. It increases the systemic vascular resistance. All of a sudden, it's harder for the right ventricle to push blood into the aorta. So the path of least resistance changes. More blood is forced to go the right way through that narrow pulmonary artery to the lungs. This gets more blood oxygenated, and just like that, the child feels better. It's an amazing self-correcting maneuver.
So, we've covered the anatomy, the physiology, and the clinical signs. Now, how do we go from suspicion to a firm, definitive diagnosis? On your physical exam, when you put your stethoscope on the chest, you're going to hear a very specific sound, a harsh, systolic ejection murmur, loudest at the left upper sternal border. Now, here is a critical exam tip, a high-yield purl. That murmur is from the turbulent blood forcing its way through the narrow pulmonary stenosis. It is not from the VSD. The VSD is usually so big that blood flows through it without making much noise. Next, you might get a chest x-ray, and on it you could see the classic textbook finding, the cœur en sabot, which is French for boot-shaped heart. You get this unique shape because the hypertrophied right ventricle pushes the tip of the heart up, and the main pulmonary artery is underdeveloped and looks concave. But while the exam and x-ray are huge clues, the gold standard for diagnosis, the test that gives you the undeniable answer, is an echocardiogram. The echo uses ultrasound to let us see the heart in action. We can directly visualize all 4 of those anatomical defects, confirming the diagnosis without a doubt. Okay, so the diagnosis is confirmed. What's next? Management basically has 2 parts. First, dealing with those acute, scary TET spells, and second, providing a long-term, definitive surgical fix. If a child is having a TET spell in front of you, it is a medical emergency. The very first thing you do is put them in the knee-chest position. This does the same thing as squatting. It cranks up that systemic vascular resistance. Then you give oxygen, some morphine to calm the child down, which also helps relax the outflow tract, and you might consider things like beta blockers and IV fluids to help stabilize the situation. Now, that emergency management is crucial for saving a life in the moment, but it's just buying time. It's not a cure. The definitive treatment for Tetralogy of Fallot is a complete surgical repair. The surgeons go in, they patch the VSD closed, and they open up that narrow right ventricular outflow tract, fixing the core problems for good.
Phew. Okay, we have covered a lot of ground, so let's take a second to pause and lock in the absolute most important concepts. When you think Tetralogy of Fallot, I want you to think Rule of 4. So to wrap it all up, Tetralogy of Fallot is defined by these 4 things. 1, a big ventricular septal defect. 2, pulmonary stenosis. 3, an overriding aorta. And 4, the resulting right ventricular hypertrophy. If you can burn those 4 components into your brain, you have truly mastered the core of this condition. And I'll leave you with a final thought to really make this stick. Since we know that pulmonary stenosis is the main thing that drives how sick a patient is, how do you think a patient with mild stenosis would present differently from one with severe stenosis? Think about the pressures. Think about the direction of the shunt. It's by wrestling with questions like these that you go from just memorizing facts to actually understanding the physiology.